Hi, my name's Julie Berk, and I'm a physician assistant that works for the Neuro-Palliative Care Division at the University of Colorado Department of Neurology. And thank you for coming to our CME. I just want to start off by mentioning why I chose the field of Neuro-Palliative. And for me, it was kind of a path that started way back at the beginning of my career. I spent the first 10 years of my career in neurosurgery. And in that phase, I had a couple of patients, even a specific patient in his 20s that I can remember thinking he had been in a big car accident, had had a major brain injury, and it totally changed his life, of course, and his personality and his physical ability. And what I started to think about is how much that changed the person, the connections and the relationships that he had, and what a key part of life that is. And then when I went on to work for other neurosurgeons in the field of deep brain stimulation and Parkinson's, I also noticed the same thing. Changes in the brain create changes to our connections, such a vital part of our life. And that happened in my MS patients, it happened in Alzheimer's patients. And finally, in 2016, I decided to go back to school to learn a little bit more about sort of the holistic care that palliative medicine focuses on. So I went to a master's program at the University of Colorado. And during that time, I was paired with physicians, nurse practitioners, nurses, social workers and spiritual care workers. And we all were put in a classroom together to learn about this approach of caring for patients. So I encourage anybody that finds this interesting to look for certificate programs. A lot of them can be done while you're at work. And the master's program I was part of was also while I was working. And there's a certification right now for nurse practitioners for palliative medicine. And we're working on a certification for physician assistants as well. So look for those resources. One of the primary parts of being in a palliative medicine practice is that it's team-based care. And so this is my team. I work with a physician and I work with 2 social workers. I work with a spiritual care advisor, a nurse, and also a volunteer. And the crux of palliative medicine is, well, the word palliate, it means to cloak. It's like an extra layer of support. And we really look through the lens of quality of life when trying to help persons cope with their neurologic conditions. So if you look at this model, it shows that the primary person is maybe a generalist or a general neurologist or a movement disorder specialist. They can then refer to a neuro-palliative provider, and we work on things like goals of care and advanced care planning, and I'll talk about more of that in a moment. And then we often, towards the end of life, will refer persons to hospice. It's important to know that hospice is a type of palliative medicine. It is designed for the last 6 months of life or so, which can sometimes be hard to predict. And it's home-based care, and it's home-based palliative medicine. Try to improve quality of life and quality of death for persons with all sorts of conditions. So this slide shows the course of neurologic illness and the points at which palliative medicine can be really important. So it shows first when someone is diagnosed. This can be really devastating for persons when they first learn that they have Parkinson's or atypical Parkinson's. And it's at that point where they have the shock of the diagnosis, they have to adjust. Maybe they're going through grief for the life that they may have planned for themselves and how it may change. So that's a really important point where referral to palliative medicine can be helpful. Care transitions come along then. Over time, their disease is advancing. They may have pain, delirium, anxiety. That's a time where we sometimes do legacy work, and we work on hospice education. Ultimately, we will refer to hospice for comfort-focused care and care that is given outside of the hospital. And then after a person dies, we try to provide bereavement and counseling support for their family members. This next slide talks about goals of care. This is really the heart and soul of palliative medicine. Goals of care is trying to understand a person's story. Also, an important part of palliative medicine is storytelling, understanding the story of a person's life and how it's affected by their neurologic condition. So I almost always start with, this is a mnemonic to help us remember what questions to ask, but I almost always start when I'm getting to know a patient with, what is your understanding of your neurologic condition? What have the doctors told you? Because this helps me to understand where their perspective is and where they're starting from. We then explore what life was before they got diagnosed. What's most important to them over the course of their life, and then how has that changed since they've received their diagnosis or they're going through their diagnosis process. Do they have things that they're worried about? What's most important to them? And then we outline a plan. And the word notify is just relaying the plan to them. And oftentimes that plan is outlined with the help of social worker and other members of my team. This other model shows how we take their values, their hopes, their story, really their personhood, and we use that information to help guide them through medical decision-making. And sometimes that means deciding whether or not they would like to be resuscitated, sometimes whether or not a surgery makes sense at some point in their care, or perhaps whether or not antibiotics are really needed, or where they should be discharged when they're leaving the hospital. So it's a negotiation between their goals of care and what are their realistic medical options. What we've learned in research is that palliative medicine and early palliative medicine does improve quality of life. We've also shown that it reduces the cost of care and it oftentimes prolongs life. This is can prolong life. This is counterintuitive, especially when it comes to hospice. Many people believe that hospice will shorten life. But statistically, we see that people who are on hospice care tend to live longer. And more importantly than that, they live with a higher quality of life. What we're hoping is that earlier palliative integration also will help both patients and family members have the type of path to death that they feel more comfortable with, and that they have a more quality death. This brings me to not only do we do a lot of discussions on goals of care with patients and families, but then we also spend some time doing advanced care planning. And advanced care planning is very important to identify who the medical durable power of attorney is. And that's who would be the patient's voice if there's a time that they can't speak for themselves because they've lost the capacity. The other thing is the MOST form. In Colorado, it's the Medical Options for Scope of Treatment form. Many states have different names for this form, but that is the form that helps decide if somebody's heart and lungs stop, do they want cardiopulmonary resuscitation? And a main point I want to bring across on advanced care planning is if someone has been diagnosed with a condition where they will have an impact on their cognition or will have worsening cognitive ability over time, it's really important to get these forms done early in the disease process so that they can take a part in the conversation and take a part in the conversation of how they want things to go as they decline and as they have progression to their illness. And another thing to know is that if they have a change in their state of health as they age, these forms may need to be redone. So revisiting them, not necessarily annually, but every few years, and definitely when they have a change of condition is important. So we do goals of care, we do advanced care planning, and then a very important aspect of palliative medicine is caregiver assessment. So we're wanting to care for other persons in the family. We know that when someone has a neurologic condition, how their family member or their primary caregiver does is going to play a major part in how they do. It's really a team effort. And we have learned with research that people who are caregivers in Parkinson's disease, in multiple sclerosis, in neuromuscular disease, and in Huntington's disease, they all have a reduced quality of life. They suffer from sleeplessness, fatigue, anxiety, depression, and even reduced immunity. So working with the caregivers to improve their quality of life is an important part of how we care for our patients. So how do we do that? Our caregiver assessment and support, we're trying to build the resilience of the caregiver. So looking at protective factors like self-efficacy, that's a person's feeling they can cope with what's to come and can cope with the current situation. We help them with emotional regulation. This is particularly important when someone suffers with cognitive change, when their loved one suffers with cognitive change and they have to deal with the communication strains with that. Social support is very important, helping them to think more optimistically, and on the positive aspects of being a caregiver. We use several interventions for this, educational materials, a lot of discussion. We help refer to home health care providers, respite care, advocacy organizations that we partner with in the community, and sometimes local or oftentimes in the age of COVID, online support. And we have a really interesting partnership with a woman in Denver who runs a business called Summit Resilience Training. She runs classes for caregivers to help them learn how to communicate with their partners with memory loss. Next, I'm going to talk about social work support. So we're doing goals of care, we're doing advanced care planning. We are working with caregivers, and our social worker is a big part of who helps with all these stages. And our social worker will help send home visits for prevention of falls. And they are going to help us find home health for families. Sometimes day programs can be provided. Really, the three situations I often find families transition into is either bringing care into the home, the utilization of day programs where the patient will go 2 or 3 days a week to a program where they have activities set up, physical and occupational therapy in a place outside of their home, and then they'll come home in the evenings and be cared for by their family members. It really helps keep the balance so that it's not, the burden's not all on the family. And then sometimes the best decision is for them to be in a skilled nursing facility. You know, I find that for some persons, this really can restore the dignity to their relationship if they're not constant healthcare providers to their spouses. So that can be a good decision in certain family situations, and we can help them make that decision. Our social worker helps us find physical, occupational, and speech therapy. Sometimes she sets persons up with therapeutic animals or sometimes art therapy, all the things that can help them to cope. The next major part of palliative medicine, and a part that's really enriched, my practice as a physician assistant in neurology who cares for neurology patients, is spiritual care. And it's really important when I say spiritual care, some people immediately think of religion, but spiritual care is not necessarily religion. It's the care and keeping of one's spirit. And how do you keep your spirits up, and how do you cope in the face of some very difficult suffering associated with neurologic conditions? And our spiritual care person really works on easing the suffering of patients and families. And he works with, sometimes for families or persons, religion can be very helpful for this. Sometimes they're drawn to music or Mother Nature, or sometimes art. There's all sorts of things that can soothe suffering. He also helps families and couples with their communication skills with one another in the face of great stress, and also the processing of grief and loss. I want to mention some common spiritual issues that we see over and over again in our patient populations. One is anticipatory grief, really common in families and with patients, just sort of having this condition where they know they will be greatly impacted, and that will, although we all die at some point, they get sort of advance notice, so they have to do some processing and some grief work. Guilt is a really common emotion, and that's both on the part of caregivers and patients. Caregivers tend to feel guilty because they're concerned about being a burden to their family and their loved ones. And caregivers or care partners feel guilty because they feel like they're not doing enough or not adequate caregivers. So that can create a lot of stress. Another thing is demoralization. What demoralization is a result of somebody going to medical visit after medical visit after medical visit, and pretty soon they feel like their whole life is their medical condition. They can really feel demoralized. It can take away their personhood. And in that case, they can become depressed and even suicidal. So we work with that emotion with families. We work with their frustration, especially that comes up with cognitive change. We work with worries and fears about the future. And this is just a list of some common existential issues. Other than those: hopelessness, meaninglessness, loneliness. People have death anxiety at the end of life, an inability to find sources of joy, love, peace, and comfort. And palliative medicine works to improve all of these. Some of the methods we use to improve resilience and cope with these very difficult emotional issues include mindfulness-based stress reduction. This is a class that was coined by Dr. John Kabat-Zinn out of the University of Massachusetts. It's an 8-week class that teaches calming of the brain and meditation. It's not that people necessarily need to take the 8-week class, but knowing that we have really good research now to support, especially in chronic pain and also other neurologic issues, that meditation and mindfulness can be very helpful in persons coping with these conditions. We use counseling and psychotherapy. Sometimes we're sending people out to other clinics for extended therapy. We also sometimes are re-engaging them in a church community or with hiking clubs, artistic outlets. We do things like, there's been some really interesting evidence on something called a gratitude journal, and it's been compared to antidepressants, and it's actually quite effective in treating depression, and it's very simple. We have patients write down 3 things that they're grateful for each day. There's a wonderful therapy called dignity therapy, which is just a series of questions. And this is kind of for the last quarter of life for people to learn on, sort of the meaning of their arc of life and kind of putting a story together about their life. And it really can add to a feeling of peace towards the end of life. And most important, and one thing that I've really learned in palliative medicine is that although neurologic illness has so much suffering associated with it, if you can get patients to identify sources of joy, it can really help lighten their suffering. So we do a lot of work with our patients on, what makes you joyful? What are the things in life that are most important to you? Because that really, we can't take away the suffering, all of the suffering. We can remove some of it with good medication, but and good, discussions. But focusing on joy really lifts quite a bit of person's suffering and can make a big impact. Another aspect of palliative medicine, so we're doing goals of care, we're doing advanced care planning, we're focusing on the caregiver, using our social worker and our spiritual care advisor to help with things. And then we're doing complex symptom management. So a lot of people refer their Parkinson's and atypical Parkinson's patients who have psychosis to our group. And our team finds it very important to use not only medications to help with these issues, but also behavioral aspects. So with psychosis, for instance, it's using redirection and calming therapies in addition to medications. And sleep is a really big issue when it comes to quality of life. When people are struggling with sleep and when they don't sleep well, it can really reduce quality of life. So I work a lot with my patients on quality of sleep. And in doing so, I use also medication and behavioral, sleep hygiene and other behavioral techniques, including cognitive behavioral therapy, very effective for sleep improvement. And we work on swallowing and nutrition. Often we're pairing with speech therapists for this. And prognostication at the end of life. This is really valuable to families to have, some sort of picture of how long the condition may go on and how long they will be playing a part as a care partner. And this is a whole nother lecture, but I will mention a few things that help me identify when someone might be in that zone of the last 6 months. I really look for 2 increases and 2 decreases, because usually the body will tell us when someone is close to death. The 2 increases I look for is an increased dependency and an increased rate of infection. It's really common for people to get urinary tract infections and pneumonias as they're getting close to the end. And the 2 increases I look for is, decreases are a decreased engagement, sort of a retreating into oneself, and also a decreased interest in food or drink, or sometimes a loss of weight, even though they're still eating. So those signals can, when the body is starting to show those signals, it's a sign that they may be ready for hospice, and to consider that with the family. Potential barriers to palliative care I want to mention. First of all, a misunderstanding. So common for people to hear palliative medicine, think it's hospice, and think it's some sort of giving up. There's also just a lack of knowledge among providers of the extent and variety of things we talk about in palliative medicine. And I think it's really important to point out that most patients report that their physicians and medical providers really underestimate the emotional impact of these conditions on their life. So having time to attend to that, in a palliative way, it can be really life-changing, because we know the mind-body connection also is so powerful. So if we can, work on soothing some of that suffering, it can really make a difference in their illness trajectory. And then there's just the underutilization of hospice I want to mention. It's interesting to note that 80% of people, when polled, want to die at home, but about 80% of the people die in the hospital. So we want to change that. So in neurologic conditions, the earlier we can kind of begin to discuss what hospice means so that people can have the opportunity to die at home, can be really helpful, and so that we stop underutilizing a service for neurologic illness. So that's the gist of palliative medicine. I hope that you learned a few things, and I hope that you'll be interested to learn more. These are my citations. Oh, if you are interested to learn more, I just want to mention this book. This is sort of the comprehensive guide to neuropalliative care, written by sort of edited by Dr. Benzie Kluger, who was my original mentor and the person that started our clinic. And finally, I'll just finish with one of my favorite quotes from Viktor Frankl. He wrote Man's Search for Meaning, a wonderful book. And it is that man is not destroyed by suffering, he's destroyed by suffering without meaning. Thank you so much. I wish you all well, and good luck in your practice. Thanks.